Greetings, welcome back to ERMP and Beyond, the pulse of clinical medicine. Join the channel as we tackle real-world medical cases, enhance our knowledge, and refine our skills with evidence-based practices. Get ready to unravel today's medical mystery with us. So, without any delay, let's dive into the depths of today's medical case discussion. A 23-year-old female patient come to the emergency department with a complaint of frequent vomiting, abdominal pain and increased urinary frequency of 2 days duration. On investigation, the fasting blood sugar is 350 mg per deciliter, serum potassium is 3.1 milliequivalent per deciliter. The urinalysis showed glucose and ketone both +3 and white blood cells of 2 to 3 cells per high-power field. What is the best initial management of this patient? A. Intravenous bicarbonate. B. Intravenous normal saline. C. Intravenous regular insulin. D. Potassium supplementation. The clinical presentation of the patient suggests a case of diabetic ketoacidosis, a serious condition that occurs when there's an acute shortage of insulin in the body, leading to high blood sugar levels and a buildup of acids called ketones. The fasting blood sugar level of 350 mg per deciliter is significantly higher than the normal range, indicating hyperglycemia. The presence of both glucose and ketones in the urine further supports the diagnosis of DKA. Additionally, the serum potassium level is low, which can be associated with DKA. Hypokalemia has been reported in only 5% to 10% of patients at DKA presentation, with values rarely below 2.5 millimole per liter. Hypokalemia and DKA likely results from a combination of kaliuresis, secondary to prolonged osmotic diuresis, inadequate oral intake, and gastrointestinal losses from diarrhea or vomiting. The urinary findings of 2 to 3 white blood cells per high-power field are normal finding. The number of WBC considered normal is typically 0 to 2 cells for male, and 0 to 5 cells for females. A high number of WBCs indicates infection, inflammation, or contamination. Typically, most of the WBCs found are neutrophils. Urinary eosinophils and lymphocytes may also be found and can be seen with the right stain of the sediment, in allergic or parasitic conditions. Let's go to walk through the treatment protocol for diabetic ketoacidosis. The very first thing we do is collect a blood sample to check the metabolic profile before we start any treatment. This is crucial because it gives us a baseline to work from. Next up, we begin with an infusion of isotonic saline. This step is vital as it helps to expand the extracellular volume and stabilize the patient's cardiovascular status. This saline infusion also makes the body more responsive to insulin by lowering the plasma osmolality, which is a fancy way of saying it makes the blood less concentrated. It also eases vasoconstriction, improving blood flow, and lowers stress hormone levels, which can be pretty high in these situations. Moving on, the third step is all about potassium. We need to correct any potassium deficits because potassium is a key player in our body's electrical system, and we need it in just the right amount for everything to work smoothly. The type of fluids we choose to give is influenced by how much potassium a patient needs. And here's an interesting fact, potassium is as osmotically active as sodium, which means it can really affect the concentration of our body fluids. Finally, we get to insulin administration. We give low-dose intravenous insulin to patients with moderate to severe DKA, but only if their serum potassium is above 3.3 milliequivalent per deciliter. If it's below that, we hold off on the insulin until we've started potassium replacement and the levels have come up a bit. We do this because insulin can actually drive potassium into the cells, making the low potassium levels even worse, and that can lead to cardiac arrhythmias. And just so you know, both for regular insulin and rapid-acting insulin analogs work well for treating DKA. Option A, intravenous bicarbonate, is not typically the first line of treatment for DKA. bicarbonate therapy is reserved for patients with severe acidosis of pH below 7, as it can lead to potential complications such as hypokalemia, cerebral edema, and delayed recovery from ketosis. Option B, intravenous normal saline, is the correct initial treatment. It addresses dehydration, restores renal perfusion, and helps to correct electrolyte imbalances. The administration of fluids alone can decrease blood glucose levels by diluting the blood and improving renal glucose excretion. Option C, intravenous regular insulin, is also a crucial part of the initial management of DKA. Insulin helps to reduce blood glucose levels and suppress the production of ketone bodies. However, insulin should not be administered until adequate fluid resuscitation with 4-normal saline has been initiated to avoid rapid shifts in osmolality and hypokalemia. Option D, potassium supplementation, is necessary because patients with DKA often have total body potassium depletion. However, it is not the initial step. In this patient, the potassium replacement should begin with fluid therapy on the 2nd hour. And insulin treatment should be delayed until potassium concentration is restored to greater than 3.3 milliequivalent per liter. Generally, administration of 20 to 40 milliequivalent potassium in each liter of infusion fluid is sufficient to maintain a serum potassium concentration within the normal range of 4 to 5 milliequivalent per liter. It's been a pleasure sharing insights on treatment of DKA with you. Your understanding is my top priority, and I trust this session has broadened your knowledge. Don't miss out on future discussions by subscribing. Your feedback is invaluable. Please like, comment, and share your thoughts on how to further enrich your learning experience. Together, let's continue this journey of discovery and improvement. Thank you for engaging with today's content.